one or two mishaps in that way. I feel on retrospect, the patients sometimes they become very bad. Some of the patients that died because of worsening of ARDS. Some of the patients have died of the ARDS was getting better, almost on verge of extubation when they had that sudden shock, which people right now call the cytokine storm. All shocks have excess cytokine. I don't know whether it's a new physiology or not. Anyway, but that is what we call right now cytokine storm. Some of them have died of that. So that is that one or two we feel they died of ancillary conditions. They're very elderly people with multiple problems, sepsis, cardiac problems. So they died of that. So that is how it is. But many of our patients who have been requiring oxygen to very high levels, say 10 to 15 liters of oxygen with non-breathing mask, but we waited till we use a criteria of whether the patient is going into tachypneic or not, or the saturation going below 85% or not. If that, we'll have to ventilate. So those patients, till that point of time, they have come out successfully without ventilation, and they have done. We thought that they would not survive, but ultimately, in spite of their advanced age comorbidities, they have success. They came out of the ventilation. A few patients who have died, they were very bad. Some of them, they had a cardiac arrest on admission at the emergency, and I feel that I could not save them anyway, already with the brain gone and etc. Initial phases that was there. Right now, we have got 6 ventilated patients. 3 of them, they have come down to ventilation with a FiO2 of less than 30% and with a PEEP of less than 5. So, 5. So I think they've got a fighting chance that they may ultimately come out unless they get complications. Let's hope for the best. On the treatment part, already discussed excellently. We are doing almost the same thing. We have used tocilizumab in just one patient. I am not at all myself convinced about tocilizumab, but my colleagues, they have suggested. So we are using tocilizumab in some patients. We are not using this double antiviral coverage. We are not convinced. Remdesivir is not available. We are using therapeutic dose anticoagulants in those patients where we have got one patient who was on a DVT prophylaxis, still got a fluid pulmonary embolism. In those patients, or patients who are remaining hypoxemic in spite of other treatments, we are switching on to therapeutic dose of this anticoagulation with or without high D-dimer. We are not depending on the D-dimer. And we are using steroid in all patients who require high level of oxygen or ventilation. Minimally symptomatic patients who don't do anything other than paracetamol. Symptomatic patients, we are using also hydroxychloroquine and azithromycin. I think that is, the fight is 2 ways. One is knowledge, lack of knowledge, and which we are developing right now. Another is big problem. Once you start a big time ward, even a single ward of COVID, I think the logistic problem is very important. Keeping the morale, training people, the RMOs again, to working with myself, I had trouble intubating patient with the double coverage of goggles and the shield. So all these things we are learning curve and we are learning them. I think people who have been handling such patients here will agree with me. Thank you.
One question from the audience that how low SpO2 in NIV ventilation can be accepted before going to the intubation and the ventilation?
We go by 86%. If it is less than 86% and with everything, we have to go for ventilation.
Susudha, only one question I am asking, 2-3 area, because you are practically managing from bedside rather than talking too much of theoretical aspect. You must face some of the problems. First is, what is your experience about the conscious proning?
We have tried it. It is good, but I'm telling you, to convince the patient to remain in that position for a few hours is difficult. Some patients, very cooperative patients, I have succeeded in 2, but many of them, they refuse, they turn around. Sometimes we turn semi-proning, that you don't have to need to lie down on your tummy, but you take almost a semi-prone sort of thing, extreme turning to one side, and convince them that you will be okay with this. We have tried, yes. But the main problem is the patient's cooperation.
Just next question I am asking, how many percentage of patient actually getting admitted to the ITU with acute respiratory failure or say in type of ARDS, ultimately you are offering oxygen and NIV, they are actually getting intubated and ventilated. basically failure of the NIV and how roughly, I know you are not prepared with the figure, but
yeah, right now we are getting the data. I'll be having the data maybe at the end of this month.
For our experience.
But I feel for every 5 patients who are receiving a lot of minimal oxygen, there are many. I'm not talking about them. The people who are really requiring NRBM or NIV, of which 1 in 5 will require ventilation.
Okay. Because that is also important to load. So approximately 20 to 30% patient may go into invasive ventilation.
Those who are requiring high level of oxygen, not all patients who are requiring oxygen.
Achha, any idea about using either steroid or tocilizumab in in your center or anything? Any idea can you give?
Steroid we are using liberally as per the CSICM and SCCM guidelines. I follow these two. I mean, my rates of studies, I don't have time. Shumit is collecting, he has collected over 400 papers and right now he wants to make a gist. I don't have, I go by ESICM guideline and the SCCM guideline, basically same. One came after 1 month after another, so it's slightly updated. So I use high dose steroid, yes. And 1 milligram, not very high dose, 1 milligram per kg of methylprednisolone I'm using in all patients who require reasonable amount of oxygen. And we are using, I have used tocilizumab in only 1 patient. I myself am not at all convinced with the level of evidence for tocilizumab. But some of my colleagues said they want. So we are doing IL-6, maybe we'll use in a few more patients.
I think there are so many questions. Dr. Kole can proceed. I don't ask because this what I was asking because so many, okay, or your participants are there. There may be questions like this. Dr.
Whatever Saurabh asks.
Right now, there are so many questions with Dr. Kole.
No, from Dr. Sarkar, Tapan Sarkar, does level of IL-6 helps?
Again, we are getting the data. Basically, what we are trying to do, again, IL-6 I can do only in slightly affluent patients. So we are trying to plot that whether this series of IL-6, they give any idea about prognostication. This data I'll be able to give you at the end of this month. But we are using IL-6 if it is above 100 and the patient seems to be ill, not very ill, initial part of the illness and the patient is having relentless fever or signs of increased inflammation with normal procalcitonin, high IL-6. Those patients have been sort of earmarked for possible use of tocilizumab, of which I've used only 1.
Just one, Dr. Dr. Kole, Dr. Suresh has joined, I think. After
Suresh,
that, I think Dr. Suresh, with Susudha, Dr. Suresh can also share his experience. Then we will come to discuss some of the issues. So
I think Suresh should first share his experience.
Dr. Susudha as well as Dr. Suresh both can give some, okay, our experience sharing sort of thing.
Yeah, thank you. No, the experience that we are having, I think, is that majority of our patients who are testing positive are very minimally symptomatic in the sense they have fever, cough, and breathlessness. The breathlessness, they don't have any real oxygen saturation. So 80% of the patients whom we have tested, we have about 75 plus, are in that category. It's only the 20% who are having symptoms, who are requiring ICU support with MODs. And in the MODs, we are mostly seeing it is mainly the respiratory failure that we are seeing. We're not seeing that much of renal failure, and we haven't seen that much of shock so far in our group of patients. So it has been mainly acute ARDS phenomena, and we have lost about 8. We lost about 8 patients so far in our this thing. About the 75 or 80s that we have. So we have lost. Sorry, can you hear me?
Yes, yes.
Okay. So we've lost, as I said, 7 or 8 of these patients, and most of them have been above 65 years of age. On a ventilator above the age of 65, it seems like very difficult. We have had some good experiences with BiPAP though. Even an 82-year-old man has survived BiPAP for us with bad acute respiratory failure. But again, it's a transient, and we've had good results with BiPAP and proning also, and awake proning. But again, as I said, the numbers are very less. We cannot say any of these things are important because the numbers are not significant as compared to what the West is seeing. And probably each of us individually combined together may have probably between the 5 or 6, between 10, 15 of us, we would have probably seen all the patients in Calcutta. But, but it's very difficult to form an individual thing, what works, what doesn't work. I think what we have seen so far is that if you come in with bad respiratory failure, you have a worse outcome. If you come in early and your oxygen requirement isn't high, you seem to be all right. And above 65, I seem to be having it bad. That's all I have to say. We've used some IL-6 levels. We have done some tocilizumab, but as I said, as Sushruth said, all of these are, these have to be analyzed and these have to be thought for as to whether they have made any difference or not. That's all I have.
Sudh and Dr. Suresh, can you just, anyone can give idea any of the innovative, not innovative, rather any of the experimental therapy like convalescent plasma or some sort of antiviral therapy? Have you used any of that? Yes, so that can you give some idea if you have used? If not, then
No,
it's okay. So because these are the actually
from
there are
when it came up first, had all our patients. Yeah, we've tried when we have HCQS was the standard treatment. We did that HCQS for azithromycin for the first 5 days, especially if your QT is okay. Then we have tried ritonavir, lopinavir in a lot of our patients. We haven't got remdesivir so far, but we have tried these two things for sure. I haven't tried ivermectin and all those things. But as far as antivirals or this thing, we have tried that. Immunomodulators, we have tried. We haven't tried cytosol, but we have tried the tocilizumab, which is an anti-IL-6 receptor antibody. So we have done all these things, but as I said, these are sporadic and they don't really, can't really make out whether it's helping or not. To me, it makes, probably nothing is making sense. Whoever is getting better seems to be getting better in spite of us and despite of us. Sushruth, your opinion?
I fully agree. I have not used this lopinavir, ritonavir combination. We have not used. We are not convinced.
Dr. Suresh, one just question to you. As you mentioned during your some of the patients are coming late. They are relatively hypoxemic, so they are going to the advanced ventilation or invasive ventilation.
Okay.
So my can I conclude like that a patient who is actually coming to the hospital and starting treatment early, they are getting better outcome in terms of ventilator respiratory failure or not? Because there are, do you understand my question?
Yeah.
So is it necessary to admit the patient for each and every case if we are apprehending about the late presentation? So does it help or not?
No, I think it's not late. It's just that you cannot ignore your breathlessness and things like that. I think probably you can't admit everybody because as I said, the population is such that if you admit everybody, it is just not possible. So the only thing we can do is, have somebody, like I give you an example, a patient who died in AMRI who was seen by us, came to our OPD emergency with a SAT 92% on room air and he looked ill and his CT was horrendous. And then we made contact with Sushruth and were able to send him. And and he eventually, the moment he got there, he got ventilated within a second. And he was ill for about 7 days at home and he was having cough and he was thinking this is nothing and he was having more and more breathless. So I think waiting 5 to 7 days with breathlessness is disastrous. I don't know whether we could have made a difference if he had come to us, say when he was only 2-3 days and his SATs were 97%, anything would have worked, but that's very difficult to say right now.
That regarding D-dimer and the ferritin, which is more suggestive
of prognostic? There is this interest about ferritin. Particularly, people were telling a certain percentage of these patients are having hemophagocytic syndrome. That is what they were trying to get. We have been actually working with using the score and everything, but we have not yet identified a typical patient of this HLH syndrome. So that is possibly the importance of ferritin. D-dimer, there is a guidance, as I've told you, to increase the anticoagulation if the D-dimer is above 2000. Guidance. But again, that is the guidance. I don't know. I mean, the data is sort of, let's say, it is sort of an idea actually. So what we are doing is we are sending D-dimer definitely, but our idea is that any patient who requires more than a reasonable amount of oxygen, we are anyway changing to a therapeutic dose of anticoagulation. And that is this is the two parameters are used this way, I guess. What we are using. I don't know. Suresh, is he doing anything else?
No, I think so. I think ferritin rising is an acute phase, acute inflammatory phase reactant. And we do see that people who have a high ferritin level tend to do poorly. And especially if in the second week it's still continuing to rise, and you know this person is not going to do. And kind of 7th to 10th day is when I think most of us have lost our patients. They seem to be all right in the ventilator for 5, 6 days, 7 days. And then whoosh, cytokine storm happens in the 8th, 9th, 10th day, that kind of a thing. And probably a rising ferritin at that particular point in time, any inflammatory marker, IL-6, CRP, ferritin, all these things may be an indicator that things are going south. So I think one of the things is how to use them, we don't know. But pure HLH, as Shushruta says, is not somebody who meets the criteria of HLH with bicytopenia and things like that is very less. But yes, cytokine release and cytokine storms are happening, especially if your ferritin tends to go up. And D-dimer, as I said, 1500 or 2000, whatever you want to use a cutoff. If it is more than that, use about 60 milligrams of cut BD. If it is less than that, just full therapeutic dose. Less than that, you can probably get away with DVD prophylaxis. That's the kind of message that is coming from across the world. And I think that's what we are also following.
Regarding the use of anticoagulants, routine use, whether you are using it regularly.
We are using low molecular heparin. Are you asking about oral anticoagulants?
Yes, oral anticoagulant.
So we have used oral anticoagulant to one patient who has proven to be having a pulmonary embolism. We have given him low molecular heparin for 7 days and we have discharged him on oral anticoagulants.
Dr. Sugoto, any question, Dr. Sugoto?
Yeah, Shushruta and Suresh probably, basically I have seen some patients in a different hospital on request. So the thing, what is your experience about seeing lung bleeds? Because it's a very catch-22 situation in going for therapeutic dose anticoagulation. We know that yes, microthrombi are happening, but the difference, yes, that's it's a pulmonary intravascular coagulation. What's your experience in seeing alveolar bleed? Because I have faced 2 patients who have alveolar bleeds and we could not give any dose of anticoagulant to these patients.
Sugoto, first let me congratulate on your speech. It was extremely comprehensive and very clear, very clear. So till now, thankfully, we had never no big issue with the full anticoagulation. We have got only one patient who had a hematoma in his forearm. That was the only thing we had with some drop in hemoglobin, but that's all. But definitely it can happen. We never had any ICH, we never had any GI bleed till now.
What I faced, and once it bleeds inside the alveolus, there is no much time.
You cannot do it.
And unfortunately, I saw 2 patients. We couldn't give anything because the first thing which came out is tube from the blood. Fine. Blood from the endotracheal tube.
That is possible. Was there
in spite, no. In spite, it's in spite of it. Yes, this patient is a high D-dimer, but this was not like a classical HLH or a mass. This patient has normal thrombocyte count. This patient has a normal INR. This patient has a normal fibrinogen, but a high D-dimer. But the patient was bleeding. So something was happening, some endothelial disruption probably because of pulmonary intravascular coagulopathy. Something was happening over there, and the patient is bleeding inside the lung.
Okay. And DAH is also a manifestation of capillary fragility because of ARDS, but very rarely that can happen. So
I was asking, what's your experience?
No, we haven't had it. To be honest with you, we haven't faced it. To be honest with you, we haven't seen this thing. We have had a patient with ICH who had come in who was COVID positive, but the COVID was not really main significant thing. Multiple small punctate hemorrhages and also COVID positive. We don't know what killed him, whether the hemorrhage happened first or COVID happened first, because he was just tested because he came in into the hospital now recently with the ICH and altered mental status, and it's a policy to test everybody, so like that, but not really. He didn't come in with a classical COVID-like picture. So, but no, we haven't seen a massive DAH or an alveolar hemorrhage causing death so far.
Jayati Bhumik, where IL-6 is measured?
Sorry?
2 institutes are measuring it: Institute of Child Health and Peerless.
Institute of Child Health and Fearless.
No,
Yes.
Dr. Lals is also mentioned.
Dr. Lal is probably yes, sir. ICH, Dr. Basu is the biochemist, and Dr. Fearless also they're doing it. So ICH in between had shut down a few days, so we were not able to get the levels. We sent the level here.
Question by Dr. Ramprasad. What is your experience regarding the false positive results?
No, I think for false positive, the problem is what is the gold standard?
Yeah.
So if there is no gold standard, you cannot really, unless you have absolutely no symptoms and you say that this is a possibility. So yes, we've had one instance where there is the pre-op recently, a pre-op commando operation where we were not able to get a good nasopharyngeal and a swab, and we had to do a oropharyngeal, we had to do some oropharyngeal swab, and we're not very sure it's positive or not.
Not false positive. The issue is important is false negative. Because as all of us know that 60 to 70% is going to be positive, and rest, even though if they are infected, it may not turn out. So we should be, false positive should not be there. So that should not be, unless you are making a mess, you're sending somebody one sample to some name of someone else, which would not happen ideally. Otherwise, there is no issue of false positive, but all of us know that the test sensitivity is 70%, up to 70%. So we can miss 30% patients, even they're infected. And as we know that even if we have 10 to 50 viruses in the system, the surface from which is collected, it will come out as positive. So false positive is possibly misconception.
So can I come in one experience again?
Okay, you carry on. Then I will tell my one experience just happened.
Again, one patient I had opportunity to see elsewhere. There were 4 samples, which nasopharyngeal and oropharyngeal swabs, which came out negative. And the 5th sample, we pushed in for a ball, taking all precautions, and the 5th sample came negative. So it's very difficult. It's very difficult to say. If clinical suspicion is high, the WHO guideline says go in for testing, go in for testing, go in for testing.
Achha. Dr. Saha, just 3-4 days before, what happened? One pregnant lady, she attended to some private hospital. So where she was she was about to deliver, means LMP, EDD. EDD was say 2-3 days after that when she attended. So that time doctor advised without COVID testing, we will not proceed for the cesarean section. So exactly before 2-3 days before the expected date, she was being tested. It was positive. For that, they refused to admit the patient and asked her to go to different hospital. So she was going in different places. So after that, what happened? Someone told, okay, you go to AMRI, but don't disclose your reports. Just go there. And in the same night, actually, she had severe labor pain. So that's why she attended to another hospital. And obviously they did emergency cesarean section. Side by side, they had also sent that another sample for the COVID testing, thinking that there was no test was being done. But second sample was negative. That was happened just exactly 36 hours apart. So, but the patient's clinical symptoms was not that much. Only I think mild fever. Patient was most likely asymptomatic. Just they called me whether it is possible to admit in our hospital or not. So that was the thing. But later on, I followed it. So in 36 hours apart, is it possible or not? But I think there was no exact symptoms like ILI or anything like that.
So if I take your case,
yeah,
so she might be an asymptomatic patient, and we don't know when the infection actually came in. So it's quite possible that she got infected earlier. And the second time when she was tested, after 36 hours of the first test, possibly by that time she was clearing the virus. So that's possible explanation. So if you rely all both the tests are correct, and second possibility is the second test, there might have been technical error also. It's a false negative also. So these are the 2 explanations possible.
Achha, Dr. Sai, another last just one. There are defined technique means RT-PCR, 2NAT, right now this is CBNAT. So just I want to take your comments about this defined testing. As clinician, we don't have too much of technical this thing, but defined lab is doing defined tests. So is it matter for a clinician, okay, that which one they will rely most and which one they will, obviously I know RT-PCR they will rely most, but can you give some idea, because there are that facility may not be there in each and every places. Okay, so that's why, have you any comments on that particular testing methods?
Yes. RT-PCR came first, and then came CBNAT. So if you have a facility for CBNAT, the advantage is you get the test report early. It takes about 2 hours. So in 4-6 hours, you can get the report. So in situation, suppose your planning for surgery as early as possible. So if you can have a CBNAT facility, you have the report, so then you can plan the surgery. But sensitivity wise, both are fine. RT-PCR are fine.
Can I tell something? Our experience is CBNAT is got more sensitive. It's more sensitive, more data. But we have got several patients who were negative in the first RT-PCR, got a CBNAT done because at that time we were doing CBNATs. We ran out of the kits. Again, we'll be doing from next week. But they came positive. They pick up better. And actually, they can be reported within 2 hours. We can make it that they've reported within 2 hours. But TrueNat, I think, is they give the group. They don't give you the specific COVID. So if it is positive, you'll have to confirm it again with a
TrueNat is only a screening test.
Screening test.
So if it is negative, it's negative. But if it is positive, you have to confirm by RT-PCR.
Right.
To all of you, it's really a very important, and we have discussed a lot of things. In between, though I was not there, but I am sure that all have included and given some inputs about the treating patients and how we go about with the new diseases. So as Shorenda has already told that we will again meet and to pursue about the disease, that what we are doing and what we are. So I hope, I thanks all of you, especially Dr. Vibhuti Shah and Ashutosh Ghosh and my classmate Shogato and Sushruta and everybody. So I would like to thanks everybody on behalf of ISCCM Kolkata branch. I hope we will meet again on the next Sunday, and our meeting will continue, and we will give all the good inputs so that we can carry on and we will win.
I should say that we have seen in the last few years that though it is not related to the COVID at this moment, but we should tell to ourselves also, we have seen in the last few years how the doctors are being treated by the community. So the time has come that the community is now respecting us. They are realizing the importance of us, and we should do our level best for the people. And ultimately, I am sure that people will respect us, and the doctor's position in the society will be established in a better way. Thank you very much.